Good morning. So hasn't this been a great conference? What do you think? So before we get started this morning, I do want to just make one announcement. I just want to express my deepest appreciation to Ashley Maxfield and Allie Sullivan. They're the NASHP staff that planned this conference. They're in the back of the room. Put your hands up. And I have to say, this went off without a hitch. I mean, all the little details that one never thinks of, they were taken care of. So thank you very much, really appreciated. So this morning we have a very special guest who will be speaking with us. And I'm pleased to present Cheryl Roberts to introduce him. Cheryl chairs NASHP's Steering Committee on Health System Performance and Public Health and is the Deputy Director of Virginia's Department of Medical Assistance Services. So if I could ask Cheryl to come on up and we'll get started. Thank you.
Good morning.
There you go.
Okay. Dr. Jerome Adams is the 20th Surgeon General of the United States and was sworn into office by Vice President Mike Pence on September 3rd, 2017. Dr. Adams, a Maryland native, has a bachelor's degree in both biochemistry and psychology from the University of Maryland, a master's of public health from the University of California at Berkeley with a focus on chronic disease prevention, and a medical degree from the Indiana University School of Medicine. As Indiana's health commissioner from 2014 to 2017, he has 4 noted accomplishments that I'd like to just bring up. One, obviously, was his big effort on helping handle Indiana's unprecedented HIV outbreak. In this capacity, he worked with the CDC, as well as state and health local officials in leading a successful range of resources to help the epidemic affecting his state. Also during his tenure, he was progressive and actually prophetic in that he spoke to Congress on the outbreak of the effect of the opioid crisis, not just on young adults, but on senior citizens. He also helped work across lines with the Medicaid agency in helping the Indiana state-based Medicaid expansion. And last but not least, he also worked with state legislators to secure $10 million to combat infant mortality and high risk of the state. He served in many leadership positions, including the AMA and Indiana Medical Association. But we know him because he was a member of NASHP. At NASHP, we know Dr. Adams as a passionate and thoughtful member of my committee, where last year he did exactly what he loves. He spoke at a session on state strategies for infant mortality, and he was an insightful and eloquent morning speaker in our plenary sessions. Yesterday you saw those leaders, he was sitting there with them last year. His motto as the Surgeon General, it says he wants better health through better partnerships. Things I know for sure, 4 things. 1, we have a Surgeon General who is completely committed and an advocate for all citizens. Number 2, I know that he will keep his relationships with the public health community. And last, I'm just waiting to see the track record of new successes from this young man. And therefore, it's my honor and my privilege to introduce you to the 20th U.S. Surgeon General, Vice Admiral Dr. Jerome Adams.
All right, well, good morning, everybody. Some of you all have seen me speak before, heard me speak before, and you know that there's something I like to do, and I'm going to embarrass Cheryl here a little bit, but we're going to do a selfie.
Okay, good.
So I want everyone to stand up, because you're going to be in the selfie. All right, I think I have most of the room, and on the count of 3, we're going to say NASHP. 1, 2, 3, NASHP.
NASHP.
Fantastic, thank you. Well, thank you so much for having me here today. It is really a pleasure and an honor to be up on this stage. I would not be where I am were it not for NASHP and for the support of all of you all. NASHP gave me a lot of the opportunities that I've had to share my message to a larger audience. It helped me understand that there are multiple different ways to skin a cat, and that what works in one state or even one part of one state isn't necessarily what's going to work in other parts. And I think that helped broaden my appeal and make me more palatable to a lot of groups as Surgeon General. One of the things folks don't realize is that my confirmation, from announcement to confirmation, was incredibly fast. Our Deputy Secretary, Eric Hargan, was announced in February and only got confirmed just a few weeks ago. And for me, I was announced in July. I actually found out on Twitter. True story. I was on vacation in Gatlinburg and found out on Twitter. And in August, I had my hearing, and in September, I was sworn in. And I credit, again, NASHP and other organizations such as yours that I've partnered with throughout the years for that. So I want to say sincerely thank you to all of you all for giving me this opportunity to represent you as the United States Surgeon General.
Thank you.
And they asked me to come and give a talk, and when I thought about NASHP, I said, these are my friends. I don't want to give a talk. I want to come up and have a conversation. And so I specifically asked if we could do that, and Cheryl said yes. She was fortunately willing to help navigate and coordinate this. But we're going to open it up for questions too. So nothing too tough, because again, I just told you all you are my friends. But hopefully we'll have a conversation about some things over the course of the next 30, 40 minutes.
We'll have questions and answers, but I want to do mine first. Okay, so, all right. It has its privileges. First, easy question for you. How has been the transition? So tell me about, one, on a personal level, moving family and friends, obviously, and changing, and then two, the priorities of what's your priorities for the next year? Great,
well, thank you for that. It has been interesting. I have if you look on my Twitter account, it says husband, dad, physician, public health advocate, U.S. Surgeon General. That's my description. And it's not that I don't think that my job as Surgeon General is incredibly important, but my position as a husband and a father are the most important to me. I define myself, as many of us do, by our professions and our degrees, and so I'll only be Surgeon General for a finite period of time. I will be a physician for the rest of my life. I will be a public health advocate for the rest of my life. And that's why I describe myself in that manner. I mention that because as far as I know, I'm the first Surgeon General in the last several decades to actually have young children while in office. I have a 13-year-old, an 11-year-old, and a 7-year-old. So when you talk about the obesity epidemic, when you talk about the opioid epidemic, I'm not just telling people what I think they should do. I'm struggling with it in my day-to-day life, really struggling with it. I am embarrassed to say, but again, we have to share these stories, that I struggle to get my kids to eat fruits and vegetables. I really do. My middle son, he probably has not had a legitimate full serving of fruits and vegetables in the past year. I mean, we've got to sneak it in here and there, and but I also think it's important that we don't act like it's going to be easy, that we share those stories of struggle and help folks figure out workarounds. So you mentioned the transition, and I'm getting there, but my kids are, they've lived in the same 4-mile radius for their entire lives. We've moved once, and they moved from 4 miles away to the house that we're in right now in Indiana. And so we're trying to figure out the move. I'm living in Washington, D.C. right now, and they're living in Indiana until we can sell the house. But that's, it's one of the things folks don't appreciate about a lot of these politically appointed positions. And I am honored and blessed to be in this role. But it's a challenge for a lot of folks, for most folks, to be able to take on these roles that don't pay as much as you're accustomed to making and that are in one of the most expensive cities in the country, and that require you to uproot your family and move them across. And I say that not because I want you to feel sorry for me, because I've got an awesome position and I'm having an awesome time, but so that you have a little bit more sympathy for some of the folks who are making that move. And most of you all, a lot of you all are in government, so you get it. You've given up the opportunity to work in the private world to be able to serve the public, and thank you to all of you all for doing that too. The Surgeon General has a couple of different jobs. The most important thing is that it's actually, that the Surgeon General is not a surgeon nor a general. And people always struggle with how to announce me or how to speak to me. I've been called Surgeon Adams, I've been called General Adams. It's actually a Navy ranking, so I'm officially Vice Admiral Adams. And I'm also not the Attorney General. I get called the Attorney General more often than I get called the Surgeon General, and I want no parts of that. And I went to visit my daughter's school, and they had a sign out after my confirmation, and it said, "Congratulations, Sergeant General." But it's Surgeon General, but it's Vice Admiral Adams, and that's been one interesting part of the transition. How many of you all know about the United States Public Health Service Corps? So when you see folks in a medical capacity wearing uniforms that look like mine, it's usually someone from the United States Public Health Service Corps. They're spread all throughout the state, all throughout the country, all throughout the world. We've got over 6,500 of the most dedicated folks working to protect and promote health throughout the country. Folks who deployed to Liberia and were working alongside the patients who had Ebola. We've deployed over 1,000 people to Puerto Rico and the U.S. Virgin Islands as part of the hurricane response right there. And the United States Surgeon General, one of the roles of the United States Surgeon General is to serve as the head of the United States Public Health Service. So I went from 0 to 3-star Admiral overnight. And that has been just mind-blowing. I can imagine. Because most people in the service don't ever get to the level of Admiral, period. And the ones that do have usually been in the service for 20, 25, 30 years. So I've had to absorb a lot of protocol, and I've got Lieutenant Carr here who is making sure that I stay straight, that my uniform is right, that I don't embarrass myself. Thank you. She does a fantastic job. But I'm just so honored and blessed to be able to be in that role leading this group of folks. And so that's one part of the job. Another part of the job that you all are probably more familiar with is serving as the nation's doctor, a voice for communication and cultural change. And that's one that I hope to really shine in. I've got a couple of priorities, but the big one, the big umbrella, is better health through better partnerships. Okay. Because you can pick different diseases, and different surgeons general have in the past, but I think that if you ultimately focus on getting the right people at the table and learning to speak in the right language, then you don't have to then play the disease whack-a-mole. Whatever disease you want to talk about, whether it's hepatitis, whether it's the sequelae of smoking, whether it's obesity, whether it's the opioid epidemic, whatever it is, you're going to be able to solve your problems if you learn to get the right people to the table and learn how to communicate with them in a language that resonates. So that's the bigger umbrella. We're going to be focusing on the opioid epidemic, obviously, because that is what's going on right now. And since I've been in office, I've been dealing with hurricanes. We've had folks working 24/7 on the hurricane response, and I never expected, as United States Surgeon General, to come in and spend the first 4 weeks of my tenure focused on hurricanes, and going to Puerto Rico and the U.S. Virgin Islands, helping with the response there. So that's more than what you probably wanted to know, but you asked about the transition, and that's been my last several weeks. I'm about at week 6 on the job now, and it's been hurricanes and dealing with the family and trying to figure out priorities.
Okay, well, since you brought up one of them, you brought up both the things we're going to bring up next. One of the things in NASHP we spent a lot of time on this week was the opioid crisis. We had a pre-conference, and actually our team put together the pre-conference, and then there was a session on opiates. Obviously, that's one of the big issues that all states are doing. What are you going to be doing, or what's your team doing in HHS in particular, Reese?
That's a great question. Most people who know me because I was the Indiana State Health Commissioner about 2.5, almost 3 years ago now, when we had the largest HIV outbreak related to injection prescription drug use in the history of the United States. Town of under 4,000 that is now up to 225 cases of HIV. The highest incidence rate of HIV in the entire country. Per Tom Frieden, former CDC director, a higher incidence rate of anywhere in the world, including sub-Saharan Africa. When you take the number of people who are infected and divide it by the 3,700 or so people that live in that community. And it was a real challenge because it was a rural community. It was a resource-poor community. It was a community that wasn't doing a lot of the things that we know scientifically we should be doing to prevent and or mitigate such types of activities, and that didn't have the capacity or the cultural, I guess, readiness to be able to accept some of those remedies. And folks hammered me and still hammer me because they want the science, the science, the science. And as Surgeon General, I'm always going to lead with the science. As a physician, I'm always going to lead with the science. However, science is just one variable in a multivariate equation when you're talking about public policy, because there's always a push and a pull. There's always a yin and a yang. If we provide services in one area and there's a finite pie, we're going to have to take that money away from somewhere else. If we want to have a successful syringe service program, for instance, it's got to be accepted in the community, because we can use all the science and set up the perfect syringe service program, but if the police officers are waiting right outside to arrest folks, then you're not going to have a successful syringe service program. So one of the things that I'm trying to do is to encourage folks, and I challenge each of you all, to think of who's not at the table. We tend to remain in our bubbles and our silos, and that really hamstrings us. Einstein said the definition of insanity is doing the same thing over and over and expecting a different result. Well, we continue to talk to the same people and say the same things over and over and over and expect a different result. The only way we're going to get a different result is to invite new and different people. So you talk about an HIV outbreak. It's not intuitive that to solve an HIV outbreak, you call the local pastor, that you call the sheriff to help deal with an HIV outbreak, that you call the local chamber of commerce. But at the end of the day, we had to bring in the business community, the law enforcement community, the faith-based community down there in order to help us be able to talk about the science in a way that folks were willing to accept it. And so that's where I come from. And when I attack the opioid epidemic as Surgeon General, the thing that I want folks to do is to continue to think about who's not at the table, who are those non-traditional partners, the educational community. Again, we worked a lot with the school superintendent down there and bring them into the fold. As far as things that HHS is doing, we've devoted over $900 million to the opioid epidemic. Just last week, the Center for Neighborhood and Faith-Based Partnerships put out a toolkit that's tremendous. I suggest you look at that. CDC is partnering with DEA and the Office of National Drug Control Policy to help identify high-intensity drug trafficking areas, hotspots throughout the community. You will be law enforcement's best friend if you can help them with their job. And a lot of you all have the data to help them figure out where they should be focusing their law enforcement and interdiction efforts. And in turn, they will work with you to help you keep people alive with naloxone, to help you set up diversion programs so that when they actually do go to those areas, they can turn people towards recovery instead of simply putting them in the revolving door that is jail. And so those are some of the things that we're going to be working on within the Office of the Surgeon General and with the Department of Health and Human Services in regards to the opioid epidemic.
Okay. Okay. two more that I want to bring up. Hurricanes, since you brought them up. We had, obviously, a lot of hurricanes. But one of the things is, and ironically, because I have family in the Caribbean, a focus on some of our other islands, like Puerto Rico, St. Thomas. Some of them did not get as much of attention, but I heard that you actually went to visit Puerto Rico. You want to talk about what you saw and what your team was working on?
It was one of those life-changing experiences to go to Puerto Rico and in the U.S. Virgin Islands. And I came in, and a few days after I was sworn in, I was supposed to go to Texas to view the damage from Harvey. Well, then Irma came along, and that got pushed back, and we said, well, let's wait because we're having to move people from Texas to Florida. And then Irma hit, and we had to deal with Florida, and I was supposed to go down to Florida. And then Maria came, and they said, hold on. And what folks, I think, don't appreciate is that it's truly unprecedented to have 3 Category 5s in a row. We have, we've learned a lot from Katrina, we've learned a lot from Hugo, we built capacity in, but those were 1, not 3 in a row that affected 3 very different areas. The other thing that I don't think folks here in the continental US appreciate is that even at its worst, and you hate to compare catastrophes, but at its worst, for any catastrophe here in the continental US, you can put people on a bus and send them 2 to 3 hours away, and they can have electricity, they can have comms, they can have food, they can have water in the immediate response situation. And conversely, when you're trying to recover, you can put phone towers and telephone poles and supplies on a truck and truck them back in to recover. We had a situation that occurred in the middle of a large body of water, and there wasn't that ability to easily evacuate folks out or to move them out or to bring help back in. I have never seen the breadth of devastation before that I saw in Puerto Rico and the U.S. Virgin Islands. Seen swaths of it before. I've seen toward tornado damage places, toward Gatlinburg after the fires came through. But usually you look and you can see where it begins and you can see where it ends. In Puerto Rico, it looked like someone took a lawnmower and just went across the entire island. It was just complete and total devastation, and the horror there is something I won't forget, but the hope is also something that I won't forget. The people there were determined that they were going to recover. The one thing that they asked me to tell everyone here in the continental US is to remind them that they're American citizens too. And interestingly enough, polls show that 50% of Americans don't know that Puerto Rico and the U.S. Virgin Islands are part of our country. But they said, we're American citizens too, and treat us like you would treat any other American citizen. From a health point of view, there are a lot of lessons learned. In the acute response, we had to worry about, again, power. Comms was a big issue. Communication was a big issue. We didn't know who needed help and where they needed help because all the comms were out. Food, water, and we're worried about those sorts of things very acutely, just meeting basic needs. In the more prolonged phase, we were worried about people suffering from chronic diseases. What happens to the diabetic who hasn't had their medication for 2 weeks? Or the hypertensive, or the person with cardiovascular disease who hasn't had access to their medication for several weeks. Mental health issues. These are people who've lost everything and can't communicate. There's just no way to fathom it, but something happened here right now, and you couldn't call anybody, your phone was gone, all the food was gone, you didn't know when it was going to end or when help was going to come, and you've lost everything that you own. You think about the mental stresses that are on people. And I think, again, that it's important that the folks in this room look at what happened there so that we can build resiliency in our own communities and learn lessons from what happened there and how we can continue to do it better the next time something like this occurs, because soon after we had the wildfires in California. It's going to be something in your communities, but make sure you've got the right partnerships and the ability to communicate in place up front, and that you run through drills in your practice. I mean, the staging of folks was so difficult. We had folks ride out the hurricane, ride out Maria on the island to try to have folks there and to hear their stories. I talked to one nurse who was on the phone with her mother when the roof was being ripped off of her mother's house. And so that's another thing people don't appreciate, is that the responders in Puerto Rico and the US Virgin Islands are also recovering. They've lost everything too. And you're going around and you're talking to the folks and you're shaking their hand and saying thank you for helping out, and then you hear their stories and you realize they don't have a house to go to. I talked to the health commissioner from US Virgin Islands, and 2-3 weeks out, she said she still hadn't heard from 75% of her staff for the health department. They were still missing. She still hadn't been able to communicate with them. So again, just true devastation, but a commitment on their part to rebuilding. And the thing that I promised them and that I promised all of you all is that we will be there with them until they rebuild and get back to where they were before, hopefully even better. That's my goal, is that we come back even stronger.
Thank you. Okay, I'm going to take you, I said I have 2 more quick ones. We always talk about drug pricing, and we also talk about drugs. So I'm going to take you back to a policy piece. Let's talk about Hep C, and how do you feel about Hep C and the drug pricing, and how that's going to play out in a bigger picture?
I had a great opportunity on Monday to talk a lot about Hep C. We had the liver meeting in Washington, D.C., where I spoke, and then we also had a Hep C convening on HHS, or at HHS. I think we're at a tipping point for hepatitis C, and I think it's very important that all of you all continue to discuss hepatitis C. Why? Because we know that the burden of hepatitis C, there are more people with hepatitis C than all of the other CDC reportable diseases combined. We know that the cost is going to be tremendous one way or the other. It's going to be even greater if we don't actually prevent and treat cases. But even if we treat cases, we're going to have a tremendous cost. So it's something that we've got to deal with. But I think the opioid epidemic gives us an opportunity to raise up Hep C and actually have discussions about it in a way that we weren't able to before. And I think a lot of you all in this room are doing some very innovative things in terms of trying to make drugs more available. The CDC is working with Kentucky on an elimination project, a Hep C elimination project in communities. And so one of the things we talked about on Monday was micro-elimination, trying to identify pockets where you can eliminate the disease, and then show proof of concept. We've got drug companies and equipment companies and manufacturers in this room. How do we better partner with them to come up with some reasonable pricing so that we actually can have elimination projects, or at least be able to get the medications to the people who most deserve them? And so, again, what I would challenge you all to do is to think about taking advantage of this opportunity. Art's going to get mad at me. Art's my former assistant commissioner from Indiana, and they always get on me because one of my favorite sayings is to ride the wave. There are certain diseases, certain topics that those of us in this room are passionate about, and we will spend our entire lives talking about them, but we'll never get that wave to catch, or we'll wait decades to get that wave to catch that we can ride in. You've got an opioid epidemic that is tragic, but every tragedy brings an opportunity. And the opportunity that exists now is that opportunity to talk about, again, mental health and the stigma that's attached to it, to talk about hepatitis and HIV in a way we haven't talked about it before, to talk about adverse childhood experiences, which is something that I'm passionate about, moving upstream. And so take advantage of that wave and have those discussions and bring other partners to the table.
Which also gives me a pitch, because my next session is on trauma-induced care for children, so you should come to my session. Okay.
You absolutely should, because I also feel like we're at a tipping point for ACEs. 2 to 3 years ago, we were trying to raise awareness of adverse childhood experiences just so folks knew about them. I think now we're at a point where people say, okay, I've heard about these things called ACEs, now what? And so the now what is trauma-informed care. The now what is building resiliency in communities. We know that one one relationship with an adult in their life can help mitigate ACEs in children and prevent them from suffering from the untoward consequences, which include teenage pregnancy, substance misuse disorder, criminal behavior, and so lots of opportunity there. And Cheryl's going to tell you all about it and how to fix your problems.
Come to my session. Okay, my last question is, you have to give us some advice. Well, physicians always give advice. Okay, so we have prescriptions written down. Everybody write down. Give us some advice, one for both NASHP and for the members here. What would you like us to do? How can we help and support the whole thing?
Well, one of the things I would say to do, this is me personally speaking, it's okay to have your partisan camps from a political point of view, but don't let that blind you to the need to work with the other side. I'm just so, it really does, it hurts me in my heart to see the dissent that exists in our country right now, to the point that if one person says they're blue and the other person says they're red, they can't even talk to each other. And so you're all from different states, but really try to find common goals. That's really what partnership is all about. Challenge to you on, I made it earlier, think of one person who's not at the table in your discussions, whatever your passion is right now, and within the next week, call them, reach out to them. Every single one of you all can do that. Call somebody who you haven't called before and invite them to your next meeting, and just start that conversation, that discussion. I'm putting out a prescription on opiates. We've got the holidays coming up. There are some key things that you all can do. You can make sure you have a discussion about the epidemic at the Thanksgiving table, at the Christmas table. It's really important that we have these discussions so that we can lower stigma and so that we can increase awareness. Go through your medicine cabinets and make sure you don't have unused opioids at home. Some of you have heard me say, I was horrified when I looked through our medicine cabinets a little over a year ago and realized that street value, I had over $5,000 of unused opioids in my house that I didn't really realize I had and didn't know how to get rid of. Opana, when we were in Indiana, was going for $200 a pill. And a prescription for Opana is 60 pills because it's a BID medication. My wife has had 3 C-sections. We both had our wisdom teeth taken out. Every time we got 60 to 90 Vicodin or Oxy, and we put them in the cabinet. And again, added it up, $5,000 worth of unused opioids. But there are real tangible things that you all can do in addition to being leaders in your day-to-day jobs to make a difference. And one person alone may not seem like it's going to make a big difference, but look at this room. All of you all together in this room doing these little things can add up to a very big difference.
Thank you. I'm going to open it up to questions. This is your opportunity to ask him a question.
Nobody wants to ask me a question. They want to get me off the stage.
No, they have questions.
They want to get to your session.
They want to get to my session. Okay. Understood.
Hi, my name is Joan Alden. I work at the Washington Health Exchange, been implementing the ACA for a while. I also work for Surgeon General Carmona under George W. Bush. So this is coming from like a complete place of love and respect for your job. I think a lot of us in the public health community are like, come on, man. Like, prevention and women's health and guns. I mean, there's a public health fund, the repeal of the Affordable Care Act. I guess from a public health place, it's a pretty dismal time to be an advocate, whatever political stripe that you have. So I guess I'm looking to you for sort of, how are you reconciling that for yourself in your job? And what would you offer to those of us in this room who are seeing funding cuts and coverage cuts and, understand the importance of prevention and obesity, but are sort of in a place where it's really hard to be in this job right now?
I thank you for that question because it's an important question. I am a public health advocate. I am a physician. And again, from Einstein, I've learned that I've got to change the way that I'm doing things. Any of you all ever heard of Maslow's hierarchy?
Yes.
It says we meet our most basic needs first. And at its essence, what I see going on today is that folks are saying, We are focused on jobs, we're focused on safety and security, and that's not a Republican or a Democrat issue. Actually, when you look at polls, Republicans and Democrats rate the economy and jobs and safety and security as the #1 and #2 issues they vote on. They don't rate health issues anywhere in the top 5, Republicans or Democrats. Health care cost will pop up there, but again, we're talking downstream. And so I say all that to say, one of the things that I really try to do is reframe public health in a way that's not me beating on someone else's door and saying, you need to care about what I care about, but talking to them and saying, here's how I'm going to help you. So I'll give you a concrete example. We're all frustrated because schools are cutting out recess, folks aren't exercising as much. Well, we go to that teacher and we say, we've got an obesity program and we need you to put it in, and it's going to take you an extra half an hour a day. And then some more of you come in and say, we've got a tobacco program and we need you to put it in, and it's going to take a half an hour a day. And then some more people come in and say, we've got an opioid program and we need you to put it in, and it's going to take a half an hour a day. And then the teacher says, well, I'm getting paid based on test scores and I don't have time to do all the rest of that. Well, how about if we go in and instead of saying, I want you to care about obesity, we go in and we say, I've got a great program that's going to help you get your test scores up. Having the kids exercise 10 minutes before each class has been proven to increase, to lower discipline problems and to increase test scores. And we actually did this in a community in Indiana. And after the program got in place and they saw the results, the teachers actually were fighting over the exercise room before the kids took their standardized exams. And so all that is to say that yes, things seem disappointing from a public health point of view, but there's also tremendous opportunity if we reframe the way we look at things and help folks understand how prevention, how the things that we care about will help them achieve their goals and where they are on the hierarchy, instead of expecting them to see it from our point of view. That's how I look at it, and that's what's been successful for me. I was able to get a syringe service program instituted in one of the most conservative states, in one of the most conservative areas in that state in the country, not by beating them down with the science, but by talking with the sheriff and saying, what's your problem, sheriff? My problem is the jails are overcrowded, and I'm worried that people are gonna vote me out of office because I can't control the crime here. Well, sheriff, you know what? I've got this great program that's been shown to decrease criminality and is gonna help stop your revolving door and connect people to care. That's how you engage. Go to the business community and they say, well, my problem is we're worried about people no longer coming to our town and spending money because we're known as the HIV and the drug town. Well, you know what? If we put in this program and we do it in concert with you, we can make sure we do it in a way where it doesn't hurt your business and actually will lower the HIV rates. And now Scott County is looked upon nationwide and across the world as a success story. So that's how you do it. So please don't lose heart, don't lose hope. Continue to fight for the things that you're passionate about. So I'm also not saying don't speak up, but I'm saying while you're being passionate, try to find a way to reframe the conversation and speak in a slightly different language so that it resonates with the people who are voting and who are making the decisions right now.
Another question.
Hi, Sherry Oley, Division of Public Health, State of Wisconsin, Chronic Disease Prevention Unit. I heard you speak at the CDC conference a few years back. I really much appreciate having you here, and very much appreciate your view on community and getting to the grassroots and inviting people to the table. How would you recommend policymakers do that? How do you bring community health workers into the profession and into the fold for public health and really elevate the contribution that they bring when you can't reach unreachable populations like in Puerto Rico, like in the opioid epidemic, like with infant mortality and trauma?
Well, one of the things that you need to do is what we're doing right here. It's coming together and sharing stories of successes. But the other thing that we do a very bad job of as policymakers is critically evaluating the programs we put in place. We say, hey, we've got a great idea, and then we try it, and then we don't really have a plan for evaluating it to prove that it works so that we can expand it within our communities and to other communities. So one real thing you all can do is try to be a lot more intentional about evaluating and having a plan for evaluating programs that you put in place, whether it's bringing in community health workers and then showing the value proposition for them, or whether it's instituting syringe service programs or whatever it is, making sure we can show folks that we're giving them the value back. Because right now, that's what the voters are voting on. They're saying, if we're going to pay taxes, we want to know what the return on our investment is for those taxes. And we're used to just saying, well, this is the right thing to do, so you should do it. And that's where the butting of the heads is coming about, I think. And I think the job is not on the voters' part 100% to see things differently. I think we should still work to try to help them see things differently, but it's on our part to try to provide the data to them that helps them understand the value of doing these initiatives.
Thank you. Pat Lincourt, I'm from New York State, the Office of Alcoholism and Substance Abuse. The addiction field was very heartened by the previous Surgeon General's report on the opioid crisis. And I see that as being as the recommendations from that report being very consistent with what you've just talked about here in terms of better health and better partnerships. And I just wondered, we were really hoping for some momentum out of that report, and could you just speak to that a little?
Well, I think Vivek's report, Surgeon General Mercy's report, he and I are friends, I'm sorry. So, but I think that was kind of the 30,000-foot view. And what I hope to do to continue the momentum from that is to really break it down and do calls to action on specific parts of that report so that folks understand, okay, well, here's the concept, here's what we can actually do in our communities. And I need your help to do all that because we need examples of places where that works. And you mentioned you're from New York. I've lived all over the country. I've lived in Massachusetts. I've lived in Berkeley, California. I've lived in Indianapolis, Indiana. I've lived in Texas. I've lived in conservative areas and liberal areas. And one of the things that I've learned is that the people in middle America don't give boo about what they did in Boston, Massachusetts, or New York City, or San Francisco, California. So we need to share examples from all over the country of how we were able to successfully institute the ideas from that opioid report, and then some of the more specific programs, so that in Indiana, Art can look at the folks in Kentucky, and when he goes to his legislators in Indiana, say they did this in Kentucky. And again, in New York, they can say they did this in Boston, or they did this in Baltimore, and share those best practices. But I'm really excited. I'm excited for the opportunity that exists on opioids, because we're now to the point where everyone accepts that this is a crisis, and we just need to do a better job of helping folks understand now what do we do about it. And it's a good place to close. Tomorrow, the president's going to be making an announcement at the White House on opioids, and we've been working on this as charged by the president and the Secretary of HHS to treat it as if it's a crisis, an urgency, an emergency, if you will, for the entire past year. Again, $900 million devoted to it. But I think tomorrow will be another opportunity for all of us to bring folks together and say, okay, the president just made this announcement. Now what are we going to do as a community? What are we going to do to ride this wave that's been further created to help bring us back to where we need to be? And I challenge you to not just look at it as an opioid problem, but to look upstream to ACEs, to look upstream to the social determinants that exist. Because as we go to a more capitated world, whether we go to bundled payments for private insurers, or whether we go to Medicaid programs that are block grants, or whatever ends up happening, we know we're moving to a world where prevention is actually going to make more sense, and the value proposition for prevention is going to be there. So you need to take advantage of that. And I want to say thank you again to all of you all for the opportunity. My office is always willing and ready to partner with any of you. I don't say I'm bipartisan, I say I'm apartisan. As a physician, I don't have the luxury of taking care of Democrats or Republicans. I just take care of whoever's on the operating room table. And so I say to all of you all, my office will be open, and we're looking forward to having a great time improving the health of our country, but we're only going to do it together. We're only going to create better health through better partnerships, and I hope I can count on all of you all as partners.
Thank you. That was wonderful. Thank you.
Thank you, Jerome. It's wonderful to have a NASHP alum in such an important position, and we look forward to continuing work with you. Your remarks have inspired us again, and we deeply appreciate you being here, and so thank you again. So this is the last time we'll all be together at this conference, and so for the last time, I want to thank you for all being here, and for the last time, urge you to fill out your evaluations. I won't say it anymore. That's it. Also, I'm happy to announce the winners of the NASHP Scavenger Hunt, who will each win complimentary registration to next year's conference. They are, so in third place is username Marie. In second place is Norm Thurston. Again. And in first place, Beth Flashner. So congratulations to our winners. And we'll invite the scavenger hunt winners to visit the registration desk down on lower level 2, where you can drop off your business card to redeem your prize. So we still have plenty of sessions left ahead of us, and our popular roundtables will be held over lunch. But since this will be my last chance to speak with you, I want to thank you again and hope to see you next year, when NASHP returns to its summer schedule. So for those of you that have been around NASHP for a number of years, remember we used to have our conferences in August. So by popular demand, and from state busy officials who now October tends to really be slammed for meetings, NASHP is moving our conference back. So when our conferences were held in August, they were dubbed the Summer Camp for Policy Wonks. So consider that, come to summer camp with us. And what better way to hold summer camp next year than in Jacksonville, Florida. So we all hope to see you there next year, Jacksonville, August 15th through 17th. Put it on your calendars, and we look forward to seeing you. And again, thank you so much. This has been quite an inspirational last couple of days, and a great way to launch the various activities and the opportunities that Jerome talked about, and moving ahead with how do we improve the health of the folks that we serve. So again, thank you so much. See you next year.